today, this morning, we're going to talk about some conceptual issues relating to equity. And obviously we began to talk about that yesterday, particularly with Daniel's very interesting presentation. What I want to remind you of before I start really is that equity has many different dimensions. Some of them emerged yesterday and some of them didn't. But what I want to emphasize is that we have to remind ourselves that equity relates to justice, and it relates to justice between groups and between individuals. That's what equity is all about. It's very important that when you're looking at equity and when you're trying to develop policies relating to equity, what you're actually trying to do is to get rid of avoidable inequalities between people. I mean, clearly there are inequalities and differences between people that are unavoidable, and you can't do anything about them. But the vast majority of them are avoidable. And so what we're looking at when we're looking at equity is how do we develop policies that get rid of avoidable inequalities between people. And in this presentation, I want to focus on inequalities in health between women. Now, in a minute, you'll see why that's very important. Because when we talk about gender inequality or gender equality, what happens is that we're usually talking about the differences between women and men. It's come to be the case that gender inequality equals the differences between women and men. But of course, there are also massive differences between women, and that's true globally, but it's also true in the context, as we saw yesterday, of Kerala, that if we were looking at the situation of the tribal people, women in the tribe, female tribal people, is that right? Female tribal people. Compared with somebody who's working in the medical school, a woman who's working in the medical school, then they're both going to be women, but the circumstances are going to be very different. And that means, as we already saw, that their health will be very different. And so what I want to do is to look not at the differences between women and men. I'm not really going to talk about those at all. I'm just going to talk in a global context about the differences between women, about the inequalities that exist between women's health in different settings. And I'm going to be using a global perspective. So I'm going to be looking at a number of different countries around the world to draw lessons from those, both within those countries and between them. Hopefully those are conceptual lessons or methodological lessons that you can then use to think about Kerala and to plan future research. So I'm exploring the inequities in health between women. Okay? If you think about how many of us have been involved for a long time in research on gender and health, and it's taken various different forms if you think about it. I mean, in the early years, women got together and said, we're a group, we're a sisterhood. We're actually unified by the fact that we've got the same reproductive systems, and that makes us different from men. So from that point of view, women came together as a group, as a single group, saying these are our needs and this is what we want to fight for proper reproductive health care. So it was very much seeing women as a homogeneous group. But as things moved on, thank you very much, people gradually, gradually began to recognize that there was a difference between biological sex and social gender. And that's very important to remember those concepts as you're thinking about equity in relation to women and to men. Because what it means is that women are in fact united, it's true, by their biological sex, and they do all have the same reproductive needs. But on the other hand, their lives are structured in very fundamental ways by their gender, by the fact that they're women, socially. And of course the same thing applies to men, that men's lives are also structured by gender, which we don't always remember, so that men's health can be affected either positively or negatively by the fact that socially they're defined as male and therefore they have to behave and do things in terms of being a male. But what that meant was that as that kind of division between biological sex and social gender gradually became apparent, and people started to write about that and think about that, that became translated into policy. And so if you look at policy documents now, international ones and national ones too, what you find is that there's quite often, not always, but often an emphasis on gender equality. And if you look up gender equality on any of the internet search machines or anything, what you find is gender equality equals the fact that societies create men as having more power, more resources, more whatever than women do. So that there's a socially constructed inequality between men and women. And that's how we've mostly been thinking about it until actually quite recently. And what I want to do is to talk about why that's absolutely important, and we'll keep on talking about it. But when we talk about equity in relation to women, that's by no means the only thing that we should be talking about. So what I want to explain is why the notion of gender equality or inequality, as it's normally used, has quite significant limitations. The first one is that, as I've said already, inequalities between women have received very little attention. So it's been mainly a focus on women versus men, but not how do women themselves have unequal experiences and therefore unequal health. So that's the first problem. The second problem is that there are very few studies, indeed, which have actually explored these inequalities. And the statistical data that we get, to the extent that we get it, in many parts of the world, doesn't disaggregate between women and men, and doesn't give us the opportunity to be able to see how there are differences between women. So the data that we have that would talk about, if you like, you could call it class and women or socioeconomic status and women or whatever, but the actual inequities between women themselves tend not to appear in statistics. We tend to have disaggregated statistics that don't really help us to solve this problem. And what that means is that we actually have very little understanding of how women's health is either harmed or promoted in different settings, because different settings, different countries, different contexts will have a different impact on the health of women. And what we have little data on is how that actually works in practice. I mean, we know, we can all say, well, you know, if you don't provide proper reproductive health services for women, then you'll have high mortality rates and so forth. Okay, we know that. But if you want to look more broadly, which I'm sure we all do, at the health of women, then we have to be looking much more carefully at other aspects of women's lives and how those are unequal in different settings. And so that's what I'm going to actually focus on today. And this is just a diagram I found the other day. So what this is showing you the countries which have data on, for example, primary school enrollment, maternal mortality, occupational distribution, and so forth, are in blue. But the countries with no data are in grey, which is quite phenomenal, really, that if you look globally, all of those countries, vast numbers of them, don't provide us with any disaggregated data in relation so that we can track the inequities between women. Okay? So, interestingly, and not perhaps surprisingly, only 38 countries, if you look at the bottom one, are providing us with data about violence against women, which is clearly an incredibly important issue. Whereas if you look at the top one, which is primary school enrollment, most countries have done that. And of course, that's been to do largely with international pressures and international policies and so on, which have focused very much on getting women into education. But I think it's a very good illustration of how little data we actually have to look at the differences between the inequities between different groups of women. So what I want to do is to put women and the inequalities between women into the wider social context. And I want to do that because obviously it's important to do, but also because of the fact that at the moment, if you're reading economic policy or social policy or anything else, the current emphasis is very much on the growth of inequity in the world. Some of you will be familiar with the French economist Thomas Piketty, who's just written an absolutely classic book on this, which kind of everyone's having reading groups about because it's so jolly difficult to understand, but very important. And so the whole trend at the moment in the world appears to be moves towards greater inequity, both between countries and within countries. And I was very struck yesterday about the discussion about Kerala, because obviously you were talking about very similar processes going on in Kerala, but as yet we haven't had the opportunity to kind of link what you're saying about Kerala into the wider global context. But I think it's very important that is part of what our discussion does. The quote that I wanted to use to illustrate that was one from Christine Lagarde. I've gone blank. I'm going to say it in French and then in English. Anyway, never mind. International Monetary Fund. So Christine Lagarde said classically last year, 7 out of 10 people in the world today live in countries where inequity or inequality has increased over the past 3 decades. Now that's really an important trend, a global trend, into which it's crucial to fit both our own analysis of women and inequalities, but also the particularity of what you're thinking about in relation to Kerala. And so my question really is, how do women and health fit into this picture of growing inequality around the world? And as I said, what we're concerned with in the context of inequities is preventable inequalities. Those inequalities that don't have to be there, that if we acted socially, economically, culturally, politically, we could actually do something about them. And the most frequently cited inequalities are those between women of what we could call a different geopolitical status, or basically those women living in rich countries or poor countries. So the first thing that comes to mind in relation to inequities between women is, do they live in a rich country or do they live in a poor country? And that's usually illustrated, and you'll all have seen the diagrams, via life expectancy and maternal mortality, because those are the ones that most clearly map onto whether you're talking about a rich country or a poor country. And it's important that both of those provide interesting illustrations of the interlinking of the biological and the social in the creation of inequity. And again, to refer back to some of the things we were talking about yesterday about the extent to which you need social science working alongside biological science, then both of those examples are obviously very important ones that need careful analysis and deconstruction to work out exactly how they operate. So I've just put one diagram up here, which is the relationship between gross national income per capita by life expectancy in women. It's amazingly hard to find these sorts of diagrams that are about women and that are not about women and men stuck together or about men. But this one is specifically for women. And as you can see, at the bottom, we could take the bottom one, which not surprisingly perhaps would be Afghanistan, which would have the lowest income per capita and also the lowest life expectancy. And similarly with the lifetime chances of dying of maternal causes. So we know that maternal causes are going to, dying from maternal causes will be very different according to which country you actually live in, and that's the most graphic representation. But also, and this came up yesterday, international inequalities or inequities may cover up very dramatic domestic and regional differences. So I've just happened to use the example of life expectancy by social class in Ireland, and you can see how there are still those extreme, even in the rich countries, still very dramatic differences in life expectancy according to your social class or your income, which comes across the bottom of the diagram. Similarly, just as an example, this is the inequalities in HIV in the African region, because in the African region, this is for women, women in yellow and men in black, that even though we talk about Africa as a huge region that with an HIV pandemic or epidemic, actually they're very different in different African countries. And so we always have to be aware that there are going to be these inequities are going to be just quite varied within what we see as one large unit. And this is just illustrating inequalities of care, and deliberately this is using the United States because of the fact that it's a very rich country, but within the United States the numbers of the amount of mortality and life expectancy will vary very much in this context by race. And so in the US they very much measure by race the inequities that are experienced. I'm not going to do this in detail because now he's told me I've only got 5 minutes. So, but you can see the shape of the pattern of how that actually works, even in a rich country like the US. I just put in this example because it's an obvious local one of the maternal mortality rates, which I'm sure you're all very familiar with in different regions of India. So how do we explain these inequalities? I mean, very, very broadly, what are the key categories we need to be looking for? The first one, obviously, is the global, the GDP, the gross domestic product of different countries, and also the distribution of income and wealth in those countries. So it's not just, is your country rich, but how does your country actually allocate resources between different people? In this case, we're talking about women. Well, second category for explaining the inequities is the proportion of the gross domestic product that a particular country spends on healthcare and on other health-related resources. So you might be in a rich country, but it might spend very little, certainly on the public sector, and vice versa. So you have to be looking at how much does the country spend. The third category, which is really important and is one that too often gets missed out, and I think lay behind quite a lot of what the inequalities that were being discussed yesterday in Kerala, which was how does a particular country allocate its national resources. And that includes social security, pensions, reproductive health care in our context in particular. So how wealthy is the country? How much does it spend on health care? And how does it distribute those resources between different people? Does it have redistributive systems of social security, or does it not? Because behind some of the stuff, again, about the tribals and about other inequalities that you talked about, was, well, how is the state distributing not healthcare, but pensions and income and so forth? But finally, in relation to looking at women's health, in particular, we also have to look at the range of national gender equality policies, because obviously countries have very different amounts of policy which is directed towards equal opportunities for women and for men. And that might include equal pay, political representation, education policy, a whole number of things. And so those issues about the differences between women and men come in there. They come in on top of all those other issues about equity within the country. So if we're looking at women, then the range of national policy will be very important. I'm just going on the last one. The issue about income inequality is an important one, which again has received a lot of attention recently, because evidence shows that the more unequal the society is, the more that you'll have social problems in that society. There's been a huge literature on this. So if you look at a whole range of what you might call social problems, life expectancy, literacy, infant mortality, homicides, teenage births, obesity, a whole range of problems, the more unequal the society is, the bigger the range of problems. So if you look at the USA, for example, it has a high rate of a lot of those problems, even though it's rich, but that's because it's a very unequal society. Whereas somewhere down at the bottom, where you've got much, like Sweden, you've got a much more equal society and many, many fewer problems. So at a macro level, you have to say, how equal is this society? And there are many different ways of measuring that. And it's something that, again, you need to come on to. I'll leave that one since you want. So gender equality policies, this is just to remind you that the UN does do some very valuable work on the issue of how do you measure gender equality in a society, and how do you map that onto the wider inequalities in income and wealth and so on. And this is the latest gender equality policy. This is the statistics which show how equal these societies are. Economically, do women earn as much as men? Politically, how many women are in parliament? A whole range of how many women are in education, a whole range of things. And out of that, the UN produced the Gender Equality Index. And so in this case, we have, at the top, we've got Iceland, and at the bottom, we've got Yemen. So we have to map these gender equality policies, if you like, onto the wider ones. So that's it anyway. That's fine. Equal pay being one example. So the conclusion, can I say the conclusion? So our success in enabling all women to achieve their potential for health, all women, will require an understanding of the socially constructed inequities between them, between the women, as well as the inequities between them and their male compatriots. So we're going to have to be looking at both of those, if you like, axes of inequality if we're going to make good policy. Intersectionality is important for achieving this, and we're going to go on, those of us at the workshop are going to go on to look at that tomorrow. Thanks.